Good morning, everyone. All right. All right. Thanks for being here. March 5th was the 33rd anniversary of Rainbow becoming an ACS verified level 1 pediatric trauma center. So what does that mean? The ACS is the American College of Surgeons. Pediatric Trauma Center, that designation comes from the state. State of Ohio gets to say who gets to be a trauma center and who doesn't. And the American College of Surgeons comes in and actually verifies that you meet those standards. Level 1 means that we meet the highest standards, and we're the only ones in the city that do this, so we can take care of the sickest kids. But beyond that, we also can educate our community with speakers like Dr. Russell, who's going to be up here in a minute, and we're doing research too. We're proud to say that this past March, just 2 months ago, we passed our re-verification again. So we are re-verified as a level 1 pediatric trauma center until 2028. The Rainbow Foundation has been a proud supporter of Rainbow for many decades. In 2018, we were privileged to get some further support from them for our trauma program, really to enhance our educational initiatives. One of the things that came from this support a few years ago was this Grand Rounds, which is the Rainbow Foundation Trauma Visiting Professor. We're incredibly proud and honored to have Dr. Robert Russell as our 2025 Rainbow Foundation Visiting Professor in Pediatric Trauma. Dr. Russell is the Director of Trauma Services at Children's Alabama and Professor of Surgery with tenure at the University of Alabama, Hersink School of Medicine. He grew up in Greenville, South Carolina, went to undergraduate at Washington and Lee, attended medical school in Charleston, where he then moved on into his general surgery training at Vanderbilt. He also completed his MPH. He did his pediatric surgery fellowship at Riley Children's Hospital in Indianapolis. He's been at UAB since 2012, right? Since 2012, where he's risen through multiple leadership positions. He sits on the editorial boards of Journal of Pediatric Surgery, Journal of Surgery Research, JTACS, which is a big trauma journal. He has almost 125 peer-reviewed publications. I looked at CV last night. He has 123. He's so close to 125. His main areas of academic focus are acute trauma coagulopathy, best practices in triage resuscitation, and the use of TAG in trauma resuscitation. One of the great pleasures of finding your niche in the medical world as you're moving through all this academic stuff is finding other people that share the same interests that you do, especially when those people are smarter and more accomplished than you. Dr. Russell is one of those people. I've got to know him through the conference circuit, and one of the few of us in pediatric surgery that have a strong interest in peds trauma. There's a picture from Pediatric Trauma Society in Baltimore, 6 or 7 years ago. Where again, a handful of us that actually have a strong interest in peds trauma. So I just wanted to say thanks, Dr. Russell, for taking the time to come up from Alabama, and I'll turn it over to him.
Level here. Well, thanks a lot. I appreciate the invitation to come to such a prestigious place, and thank Dr. Dine for the invitation and the pictures that I was much thinner and younger in that last picture. So I've been looking forward to my visit, and I hope that y'all will learn something today. The title of my talk is Current Challenges in Pediatric Trauma and Improving Resuscitation Strategies. As far as disclosures, I don't know if y'all have heard of the MEDIC 2 study, but it'll I think change the way we resuscitate pediatric trauma patients. It's a randomized trial of whole blood and use of TXA that's really run out of Pittsburgh, and I'm the medical monitor for that study. It's not going to have any influence over my talk today, but I will mention it in a little more detail at the end. So obviously everybody stands on the shoulders of other folks, and this is my hospital and my group of fantastic pediatric surgeons that allow me to do the work that I do and cover my patients when I'm gone, and sort of allows us to sort of investigate the niche that we enjoy. And so I just wanted to give credit to my group and appreciate everything they do. And then, mentors. So um, mentors are so important, and I'm not going to mention all these folks. You may know some of these. Some of these are from residency, some are from fellowship, and some are at UAB, but research and clinical mentors who sort of have helped me to get where I am today. So, and then for all the trainees and research fellows that I've had the pleasure of being a part of their training, certainly y'all probably teach us more than we teach you. So continue to do that, and please continue to push us. So I'm going to talk a little bit about the history of trauma fluid resuscitation and how that has changed. It'll be a very quick tour de force through that. And then I'll review a little bit of pediatric trauma epidemiology. And then I'll talk really the main part about the hemorrhagic shock consensus guideline process that we went through 3 years ago now. And then talk a little bit about future research and clinical priorities. So the history of trauma fluid resuscitation. In 1829, James Blundell, who was an English obstetrician, was the first person who really gave a successful whole blood transfusion. And this was for postpartum hemorrhage. The husband gave blood and the wife received it. And so that was kind of the beginning of transfusion. And in 1918, Oswald Robertson was the first to create really a blood bank in World War I. And he provided 22 transfusions using this Winchester bottle, which is really simply a collection device that had whole blood and preservatives in it. And then fast forward to the 1940s and World War II, and the sort of American Red Cross led to development of the blood bank, the sort of soldier blood bank, and the widespread use of dried plasma. And so to sort of continue, the pendulum has kind of swung from whole blood to components to crystalloid, and it'll sort of shift back. So the first person to sort of advocate for whole blood was Colonel Edward Churchill, and he was a cardiothoracic surgeon, and he was in the North Africa campaign. And really the U.S. Army charged him with sort of studying whole blood and the necessity and the war. And so his conclusions were that whole blood should be the agent of choice. And he felt like it reduced mortality, it reduced wound infections, and that plasma should only be a supplement for whole blood. And he actually brought that back to the Army, and they kind of rebuffed him. And so he then went to the New York Times and gave his rendition. And so there was some controversy there. So to fast forward, component blood therapy then became the sort of vogue in 1980s when transfusion medicine was developed. The blood bank would separate the components. And then in the 1970s, there was also some research going on at Parkland Hospital, and James Carrico and Tom Shires really studied crystalloids. And what they did is they studied animal models and had some radio marked labels, and they saw that with a controlled resuscitation, there was a big extracellular fluid leak. And so they were seeing this, and they gave lactated ringers along with whole blood, and they saw that the extracellular fluid leak was less and the cell volume was better. Unfortunately, their research and their models were sort of misconstrued, and so they were misconstrued just to use a lot of crystalloid. And so this supernormal resuscitation strategy of using lots of crystalloids was sort of perpetuated from really the 1970s to the 2000s. Does anybody know anything else about Carrico and Shires? So Carrico was the first person in the trauma bay when Kennedy came in after assassination. And Tom Shires was the chief of surgery at Parkland. He was actually given a lecture in South Texas. They actually flew him back to Dallas. He operated on Connolly, the governor, saved his life. And then 2 days later, when Lee Harvey Oswald was shot, he operated on him and couldn't save his life. So interesting fact about those two gentlemen. So in the Vietnam War, you can see here, there was large volume crystalloid resuscitation, and there was fluid overload and hemorrhagic shock, which led to increased inflammation and what was reported as worse clinical outcomes. So certainly the pendulum shifted. And then in sort of the decades of the 2000s, we've had the large clinical trials that were looking at component resuscitation, so PROMIT, PROPER, and PAMPER. These looked at large hemostatic resuscitation, really massive transfusion in adults, and also pre-hospital use of plasma. So again, the pendulum kind of shifted back to component therapy. And then now I think we're in the sort of age with the TROOP trial, which is led at UAB, and then the MEDIC-2 trial, which is led out of Pittsburgh, of whole blood versus component therapy. So I think the answer will be there to shift back to whole blood. So let's shift to a little bit of epidemiology about pediatric trauma. And this is a slide I show in a lot of my talks. And on the screen right here, you can see the color variation in the states. And this is the estimated percentage of children that live within 30 miles of a high-level pediatric trauma center. The darker states, which most often are in the Northeast with the sort of group population, have the highest percentage of kids that live within 30 miles. And then you can see as the colors get lighter and white, less than 0 to 25% of kids live within 30 minutes of a pediatric trauma center. So in Alabama, you can see we're sort of in the mid group. Y'all are a bit better in Ohio. But if you look at the graph on the right, which looks at county differences in pediatric mortality after motor vehicle collisions, so blunt trauma, what we mostly see, I think if you overlay those two graphs, you can kind of see that the mortality increases in the areas that have the fewer pediatric trauma centers. And I'll get back to this point because I think the Pediatric Readiness Project, which Dr. Dingledine is a part of, will really, I think, give us the answer to how we improve this. So our children are just small adults. And certainly I think everybody that is involved in pediatric medicine and pediatric trauma would say no. Certainly we adopt a lot of the resuscitation strategies and things from adults. But I don't think that everything should be a blanket for kids. So really what we want as pediatric surgeons and pediatric providers is for this little guy to grow up to be this big guy. And so there are many practices that we generalize, but I think we really need to sort of look at the data and see what translates well. So let's sort of talk about hemorrhagic shock, coagulopathy, and resuscitation strategies. I don't know if anybody's seen The Bear, which is a series, but their mantra is every second counts, and I think that's applicable here. So this is a graphic from a study using the National Trauma Registry from 95 to 2001. And you can see that deaths from hemorrhagic shock are the third most common. CNS injury, hypoxia are the most common. And then the third most common is hemorrhagic deaths. But you can see the hemorrhagic deaths happen really fast. Within the first 4 to 6 hours, a majority of the kids have died or had mortality. And so we need to act quickly. And how do we do that? And a very important, I think, physiologic change that we may not educate everyone well enough is the sort of compensation ability that kids have that adults don't. So you can see on the screen right, as an adult with increasing percentage of blood loss, they have a slow dip in their blood pressure. They get a little bit tachycardic unless they're on beta blockers or other medicines. But in children, the ability to compensate is remarkable. So you can see as the blood loss increases, the child's heart rate stays pretty stable. The blood pressure stays stable. You can see a little bit of tachycardia when the blood loss increases, but their blood pressure is pretty rock solid until they're not. And as some of my partners say, they're okay until they're not okay. And sort of the challenges is identifying this in the field, in the trauma bay, even after admission. And so sort of the 30% blood loss is key. And if you sort of relay this into, a child you may take care of, 15 kilograms, that's a Coke can of blood. So they can get in that dangerous space very quickly. So trying to recognize that and educate folks about that is important. So this is a study from Randy Bird. He's done a lot of research around sort of transfusion and massive transfusion protocols at pediatric trauma centers. And this is looking at the TQIP data. So really 97% of our trauma folks are fine. They're not going to get any blood. They're going to get admitted or discharged and they're going to be fine. There's about 2.5% that get blood, but no massive transfusion protocol. And there's about 0.5% that get a massive transfusion protocol. So we're not really practiced at doing this. So I think that's the important part is we just don't do this as often as the adults. And so how can we sort of recognize this and get better at what we do? Just for reference in adults, about 8 to 15% of all adult trauma patients get at least a unit of blood, and their massive transfusion rate is about 5%. So along with their volume and that percentage, they see this on a day-to-day basis. So some of the leaders in this field, Julie Leonard, who's just a stone's throw away, and Phil Spinella this was MADIC 1. And so this was a prospective observational study looking at life-threatening bleeding in children. And this was not just trauma patients. This was 24 centers. This was over 4 years. And they had 450 children that got massive transfusion. And that was either 40 mLs a kilo over 6 hours or transfused under their massive transfusion protocol. And there were some international centers here. So you can see 4 years to accumulate that many kids. We're just not doing it very often. So about half were trauma patients. The trauma population was, as we usually see, 8 to 10 years. Moderate injury severity score, mostly blunt. And their mortality at 6, 24, and 28 days is there. So it's between 17 and 36%. So pretty similar to other trials, but just sort of gives you an idea of the sort of amount of massive transfusion that we see. So when I started at UAB, this was 13 years ago now, kind of moved to trauma-induced coagulopathy. One of our PICU fellows and one of my partners actually published one of the first studies just looking at trauma-induced coagulopathy in children. It had been pretty well studied in adults, and with the Pamper trial, things had moved along quite a bit more. But you can see, again, 75% of our kids hit the door with normal coagulation studies. So, but that percentage that's just a little bit above 1.3 to 1.4 all the way to 1.8, you can see the drastic increase in mortality. So most of our kids are fine, but when they're not, you really need to pay attention. And the Pittsburgh group on the screen left took this a bit further, and they looked at their kids when they hit the door, and then at 24 hours, and you can see, despite them resuscitating, some kids' coagulopathy got worse, and those were the kids that had the highest mortality. So there's something about that we need to pay attention to. So sort of traumatic coagulopathy in kids, certainly there's unique patterns. There may be developmental coagulation patterns in infants and young children that may be different. I don't think that's fully worked out yet. There's certainly special considerations that we can't lump everybody into the same group. TBI may have a different pattern, and abuse, certainly the time frame of when they were abused versus when we see them, they may be way farther out on the curve than just a acute trauma. It's seen in various percentages, so 10 to 77% mostly in TBI populations, but 25 to 35% of polytraumas. And so we have a lot of challenges still. How do we continue to improve in the face of these rare events? How do we have common definitions so the trauma patients here are similar to the ones that I have, and how do we make those definitions the same? What are the best resuscitation strategies for children? And then how do we set research priorities moving forward? So as often happens at meetings, the best ideas come about over drinks at a bar. So Phil Spinella and I were doing we're at a consensus conference, and we were talking about pediatric trauma data, and sort of about how it was mostly single institution studies, and it's using various definitions. Coagulopathy is not defined the same at every place, and so we sort of, this light bulb went off, and we found this RFA, and it was for a consensus conference. So I'd done a few consensus conferences, but I was like, I'm not sure I really want to lead it. But Phil's busy, and he said, I think you should. So I said, okay. So what is a consensus conference? Basically in the 1960s, the NIH sort of came up with this structure, and it's basically identifying expert stakeholders, reviewing the data and the literature that's current, and developing guidelines and recommendations, disseminating those results, and then setting research priorities for the future. I actually have a whole book on consensus conferences. So if you're interested, it's that book on the left. I can't say I read it all, but I certainly use it as a resource. So we applied for a grant and submitted the application in July of 2019, and it was funded after merit review in January of 2020. And so we had it planned for 2021, and of course, COVID hit. So the first planned date was in April of 2021 to 2020. That was in the sort of height of the pandemic. Then we were going to try again in 2021, and that was sort of the second wave. And so finally we pulled it off in 2022. But basically we just started with what we thought were key questions, and we focused it on hemorrhagic shock and pediatric trauma. You have to be really focused, or you can get sort of in the weeds and be very broad. We did a literature review. The UAB librarians were very helpful. I don't know if anybody's used Covenants, but it's a software program that can sort of bring in all your abstracts, and you can review those with your colleagues. Then we had a key stakeholder group, so multidisciplinary, very diverse group. We were going to include international experts, but the NIH wouldn't pay for international travel during COVID, so those folks were sort of left out, unfortunately. And then this was done with the Delphi process, which certainly I had to educate myself about. I'd done a few consensus conferences with some pediatric critical care experts, and so I was kind of familiar, but when you're running it, you need to be very familiar. And then reading manuscripts and assessing for bias, which is not something that kind of usually do on a day-to-day basis. So I had three excellent folks that helped me review the literature. One of our former fellows, Aaron Beckwith, who was in the military and is finishing up his fellowship at Michigan, and then Peter Abraham, one of our general surgery residents. And then a excellent consensus committee. You may recognize some of these folks as your colleagues: pediatric critical care medicine, pediatric surgery and trauma surgery, pediatric pathology and lab medicine and hematology, PZM and peds anesthesia, and then an implementation scientist. So this was all pulled off in April of 2022. This was in Birmingham, and this was the Pediatric Traumatic Hemorrhagic Shock Consensus Conference. A lot of words. So we reviewed over 2,900 abstracts. 45 met our criteria. So you can say that our pediatric literature is not as great as we want it to, but it's getting better. The literature quality was low. So luckily, Raul Coimbra, who's the JTAC's editor, agreed to publish our supplement. So this is a QR code to the supplement if you're interested. Has the consensus statements manuscript, has our research priorities manuscript, and then there are several review articles and some opinion pieces that were written. And this was published in January of 2023. And so the key questions we focused on were use of pre-hospital blood, tourniquet utilization, which I think was an easy one, airway and blood pressure management, which we didn't come to any consensus on. And I think Julie's going to run a trial looking at that. Blood products and fluid resuscitation, which fluid utilization and hemostatic resuscitation, which was a big one. The role of hemostatic adjunct, so TXA, and then use of TEG. So these were our main questions. And sort of when you think about wording these, there's a specific way that consensus statements have to be worded, and it's based on a hierarchy, and it's based on the degree of certainty in the literature. So we didn't have any literature to say carry out or do. That's sort of randomized controlled trial study. So most of ours are we suggest or might be considered. And certainly you revisit these guidelines every 3 to 5 years, and certainly those statements can be updated as the literature gets better. So as I've given talks about this over time, I think it's sort of best to group it into sort of pre-hospital and then in hospital, and then use of hemostatic adjuncts. So so we'll kind of go through those. So first in the pre-hospital setting, again, this is an uncommon event. 2.5% of patients will get a blood transfusion, 0.5 a massive transfusion. So in the pre-hospital setting, what are our challenges? So IV access, what sort of fluids do they have? Blood? Do they have plasma? And the EMS, there's less familiarity with EMS with kids. They often get sort of uptight about having a kid and transporting a kid. And there's limited high quality literature in this setting. So we felt that it was very important to suggest a permissive hypotension strategy. So in adults, there's still this suggestion of permissive hypotension, allowing hypotension until you get definitive hemorrhage control. This is not good in children. So again, you know that curve. So if you let them start getting hypotensive, you don't resuscitate them, they're going to crash. So we suggested against a permissive hypotension strategy, and basically suggested resuscitation goals that optimize end organ perfusion and oxygen delivery. There's not much literature, but I think it's reasonable for pre-hospital transfusion of blood, and I'll detail a study next that was published after our consensus guidelines. So I think it's fine if EMS has blood and they need to give it, give it. And then an easy one, I think, was children with exsanguinating extremity hemorrhage. We recommend use of tourniquets. So there's lots of literature that tourniquets are safe. There's Stop the Bleed that ACS has sort of educated, I think, over 4 million providers now. So if you put it on appropriately, if you put the time on, then it can be used safely. Certainly in military settings, there's some caveats to that if they're being transported long ranges, but I think overall it's safe. So after we published our consensus guidelines, the Pittsburgh group published a study, and this was a great study. This was about the use of pre-hospital products. So 599 children they looked at, 70 received pre-hospital blood transfusions, and they did a propensity score matching for those that didn't receive any transfusion in the pre-hospital setting, but received it in the ED. And there was a reduction in mortality for those that received pre-hospital transfusion of about 50% at 24 hours, and there was also a reduction of in-hospital mortality of about 50%. So if you have blood in the pre-hospital setting and the child needs it, give it. So now we'll sort of move on to the resuscitation phase, and that can be included in the pre-hospital setting. But basically, ATLS recently has changed its guidelines, and it used to be you give 20 per kilo of saline, and if they didn't respond, you give another 20 per kilo of LR or saline, whatever your fluid of choice. And then you think about moving to blood. Well, they've sort of bypassed that and give saline initially, and then if they don't respond, think about moving to blood early. And sort of the study, I think that best represents this is Stephanie Politis and Rich Falcone put together an East multi-center study, and this was from 2020. And they looked at, they pulled together 24 pediatric trauma centers, so quite a poll. There was about 700 kids, the usual blunt and usual age of our pediatric trauma patients. And those patients that about 50% of those received greater than 1 crystalloid bolus. About 20% received PRBC, so that's higher than the literature I've quoted you, but sort of a sicker population. And then 10% received massive transfusion. Of those patients that received greater than one crystalloid bolus, 53% of those kids ended up getting a transfusion. And those kids that got multiple crystalloid boluses had an increase in hospital stay, an increase in ventilator time. And so this is sort of the creep towards more use of blood products and less crystalloids in resuscitation. And this is bled into the pediatric population. So now we'll talk about ratios. So this is probably the area where we have the most data. And I'm only going to review one study. I think it's one of the best studies. It's 3 institutions nationwide, Shock Trauma and Harborview, and they came together and looked at the pediatric TQIP database. And it's about 130,000 patients. 583 received massive transfusion, and there was about a 20% mortality. And they broke it down into high, medium, and low fresh frozen plasma to packed red blood cell ratio. And they looked at 4 and 24-hour mortality. And those kids that were in the high ratio group, they had about a 51% lower risk of mortality. And those in the medium ratio had about a 41% less risk of mortality. So trying to decrease the plasma deficits is important. So trying to get about a 1-to-1 ratio is important. And sort of the only downsides that they found in the study were that if you got too robust with your plasma resuscitation, there was a higher risk of DVT. So not going greater than 2-to-1 of your FFP to packed red blood cell ratio can be detrimental and lead to DVTs. So we need to think about equaling our resuscitation. There's also data on platelets that I'm not going to get into. Shows a higher platelet ratio to blood ratio can improve mortality. So then the next question is sort of use of whole blood in pediatric trauma, and this is becoming much more common in adult centers and in pediatric centers. And again, there's 2 ongoing randomized trials looking at whole blood and trauma resuscitation. So what are the perceived benefits? So it's sort of an efficient alternative to component therapy. And by that, I mean, you don't have to give 3 products. You don't have to have multiple IV sites. You can just give 1 product and you can get the 1 bang for your buck. It does have some hematologic advantages. It has a higher hematocrit. The platelet function is proposed to be better, and has greater factor concentrations and less additive solutions. So you're getting less overall fluid and more hemostatic product. There are challenges. So has a limited shelf life, and is it practical for low volume centers? I, as a proponent of whole blood, are still having trouble getting it at my pediatric trauma center. And it sounds like it's not being used here as well. So how do we group with adult trauma centers that are close by so that we don't waste it? It can be reprocessed. It can be used. UAB uses whole blood on a daily basis. So just trying to work with your blood bank and trying to get those products available. Some of the smaller studies have shown that there's an increase in AKI or ARDS in those that get whole blood, but those studies have not been reproduced. So I think those are less worrisome. So the Pittsburgh group has really been on the forefront of whole blood and pediatric trauma. So Christine Leeper, Phil Spinella, Barb Gaines, who now moved to Dallas. But they've started this, and this was in 2020. So their first study was just to show it was safe. Their second study, which is this, was they're comparing with propensity score matched component therapy recipients over a 3-year time period to their whole blood recipients. And although it was a small population, they did show faster resolution of shock, a lower post-transfusion INR, and decreased product transfusion. So with whole blood, you gain those advantages. And then they subsequently published a larger paper in Annals that looked at, and they go from 1 to 17, and they're using 40 per kilo of whole blood, and then if they need additional resuscitation, using component therapy. but those that received whole blood had a decreased 24-hour and 28-day mortality. So strong data, small studies, single center studies. I think we need to wait for MADIC, but I think it is useful, and if you have it, I think it is worth using. So what were our recommendations for resuscitation? So again, based on the literature for component resuscitation, is trying to target high plasma to PRBC ratios to minimize your plasma deficits. And also the literature I didn't detail is to target high platelet to RBC ratios to minimize your platelet deficits. And then the one that was most argued about was how to word this. But we felt like at the time, the data suggested that the use of low titer group O whole blood, if available, might be considered over individual blood components. So that was the recommendation I think that was most argued about amongst our group. So what about use of TXA? Our group felt that in traumatically injured children with hemorrhagic shock, the empiric use of TXA within 3 hours of injury might be considered. There is data. The Pediatric study, which was a combat study from 2014, looked at about 700 patients. 10% received MTP, 76% required a surgery, and 9% got TXA. Those predictors for TXA were severe abdominal or extremity injury and a greater base deficit, and those that received TXA had a independently associated decreased mortality. And there was no increase in thromboembolic events. And then the MADIC-1 study, which I detailed earlier, that's just a Kaplan-Meier curve of their patients that received TXA, and they showed a decreased 6-hour mortality in kids that received TXA. So I think if the data supports it, I think if you use it in the right setting within 3 hours, I think it's a useful adjunct. So what about TEG? So thromboelastography, kind of a more detailed look at the coagulopathy rather than PT, PTT, and INR, and can be quicker if you have rapid TEG. So we suggested that if you have it, it can be an adjunctive monitor to sort of monitor coagulopathy. And my take on this, the literature is not great, but I think I usually say when the dust settles is probably the best time to use it. So you've gone through your resuscitation phase, you're getting to the PICU, you've either given MTP or aggressively resuscitated a child, and you kind of want to see where they sit. And the maximum amplitude is probably the best measure to look at. And we recently had our national meeting, and Lucas Neff gave a great talk about TEG. And the maximum amplitude is probably the best value. And it's going to tell you how you're doing with platelets and how you're doing with fibrinogen. Sort of as the dust settles, what do you need to sort of buff up? And so I think if you have it, probably that's the best time to use it. It may not be useful when they come in the door necessarily because it's a little bit delayed and you're going to be resuscitating and then you're going to be 30 minutes behind to what your tag shows. So this was kind of damage control resuscitation for adults, rapid diagnosis, rapid anatomic control, limiting crystalloids, balanced resuscitation or whole blood if you have it. And then sort of we took out the permissive hypotension and included the antifibrinolytic. So looks quite similar, but there are some scenarios that will apply to kids that won't apply to adults. So sort of to wrap up, we sort of ask ourselves, are we ready for these challenges? And these are a couple local examples. Certainly, I'm sure y'all have some local examples. In 1963, we had the 16th Street church bombing in Birmingham. And unfortunately, none of these 4 young ladies made it to the hospital. But are you ready for that if they do? In 2011, we had tornadoes that were in Tuscaloosa and Birmingham. This was just before I joined. And I think, had 30 admissions, 30 kids, and my partners did a fantastic job. But how do you prepare yourself for that? And then you can sort of insert really anything here. The Sandy Hook shooting was in 2012, but you've got Blacksburg, Uvalde, Parkland, Columbine, Nashville, any of those recent events. So how do we make ourselves and our system ready? And so I'm sure many of you heard, Mike Dingledine's a big part of this, but the Pediatric Readiness Project, this was launched in 2013, and this really was a startling fact for me, is that 80% of pediatric patients that seek emergency care are seen in emergency departments and see less than 15 kids a day. So how do we prepare those folks, not just for trauma, but for normal pediatric diagnoses? And so this sort of plan involved trying to get those centers ready that don't see kids, and it's, lists all these different variables that you go through. But the literature is very strong. This sort of shows in the every center is given a sort of a score from 0 to 100 based on their readiness to deal with pediatric patients, like the care coordination and the sort of physician, nurse personnel, and QI and those things. So the graph that shows in the gray bars that the number of EDs at each pediatric readiness score, so 0 through 100, and the blue sort of line, squiggly line, indicates the median annual ED volume of children. And basically the study was over 370,000 kids that were cared for in almost 800 EDs. And in the cohort of injured children who received care in the ED and the highest quartile readiness, there was a 42% lower odds of death compared to those similar children in the lower readiness EDs. And then Dr. Dingledine was part of this study with Aaron Jensen. They sort of looked at pediatric readiness and mortality for injured children treated at the U.S. trauma centers. And I think this was striking, that that those folks that were treated at the areas with the highest readiness were significantly less likely to die. But it wasn't just pediatric trauma centers. It was adults, it was level 2s, level 3s, and undesignated centers that were educated that were able to improve the mortality of the kids that were seen there. So education is important, and this project is important. And I think the work that you've done is great. So what are our future research priorities? And some of this is included in the research priorities manuscript, but pediatric readiness is very important. So local, regional, national, we have lots of societies: Pediatric Trauma Society, the American College of Surgeons Committee on Trauma, our national APSA and AAP. We can all align to help educate these folks. And then sort of defining and standardizing and improving the collection of what the NIH calls common data elements. So if we define pediatric traumatic coagulopathy at a INR greater than 1.5, we need to have standard definitions around the country so that we can compare patients, equal patients to equal patients. And then sort of improvement in the identification of traumatic hemorrhagic shock in kids. So we can't really use our state-of-the-art resuscitation strategies until we recognize it. And so that's an important part. And then certainly clinical trials, which I've mentioned before. And these are the two that I think are important. The MADIC-2 trial is funded by BARDA. And again, Phil Spinella and Christine Leeper are the PIs. And that's $34 million randomized platform trial looking at trauma and life-threatening hemorrhage. So there's a component therapy versus whole blood. There's a TXA versus placebo. And the way they've set this trial up is they can add additional therapies along the way if something comes up in the next couple of years, because this will be a long-term study. And then PD part is from PCARN, and that's looking at how we take care of the airway and maintain breathing in children in the pre-hospital setting, and that's comparing bag valve mask to ET tube intubation or supraglottic airway. And that was sort of an area that we tried to come up with some consensus guidelines, but there just was no consensus. So sort of in conclusion, pediatric trauma care is certainly multidisciplinary. I think we have lots of people at the table that can contribute. And so using all of the folks that we have to help move this forward, we have logistical challenges. And so we need to sort of shrink that 30-mile radius. So with pediatric readiness, with education of trauma providers to sort of help the kids to have better care. And then sort of that involves continuing the education of frontline providers and anybody that can assist us with pediatric trauma care. So appreciate the opportunity. It's been fantastic visit. I look forward to the rest of the day, and I'm happy to answer any questions.
Thanks, Rob. That was fantastic. Can you speak a little bit about RH status and whole blood?
Yeah, so I didn't include that, but there's mounting data. So whenever I talk to Phil, he says there's a 1% risk of a child getting hemolytic disease in the newborn from transfusion if the mother gets a transfusion. There's also I was part of a panel at AABB. There's an organization called Allo Hope, and that's actually mothers that have been transfused either through obstetric hemorrhage or trauma and have converted RH status because they got RH positive. And they're still huge proponents of transfusion. So Mark, if you want to look up the data, Mark Yazer from Pittsburgh has published significantly on this. I can't quote you all the details, but they've done studies where they survey studies with moms or childbearing mothers about sort of where's your risk cutoff for if you're in a life-threatening accident and you have potential for getting alloimmunization, what would what's that threshold to get transfused? And it's very high. I can't remember the percentages, but even with that, the moms that I heard speak at this meeting, there are ways that they can get by that exchange transfusion. And so many of these have had children, even though they have been alloimmunized and the children. Yeah. Hey, Ken, how are you?
Quick question for you. So Grant Wakikio and Phil, when they were in St. Louis together, did the TXA studies, did some octoplasm studies, and for pre-hospital, and the data was not exciting. Why do you think that's true? If giving it before hospitalization didn't seem to improve a lot of the outcome measures.
So given TXA, I don't know. I haven't read that specific study, but I think there's obviously there's data on both sides. My opinion, I think the data from MEDIC 1 and from the Pediatric study seems to be improve outcomes. I don't know what their time frame was from time to injury to given the TXA, but that's also important. But I think MEDIC 2 will tell us for sure, hopefully.
This is a much less sophisticated question. I'm just a general pediatrician, but if I heard you right, the incidence of trauma-associated coagulopathy is significantly higher with traumatic brain injury than other forms of trauma. Any understanding of why that is?
Yeah, so actually had a basic science lab looking at this for some time that I just stopped. And so yeah, so I don't know the answer, but so there is a thought that with brain injured tissue, there's an increased release of thromboplastin. And we actually showed in animal models that it actually is in the systemic circulation. So it crosses the blood-brain barrier and gets in the systemic circulation. That's my theory, but I did not prove it. So, but that would be my best guess.
All right, Glenn Tinkoff, I'm an adult trauma provider.
Mm-hmm.
And I should not have take care of any patients that I can hold in one hand.
Yeah.
So, but I've seen this from the adult side, and I also seen this from the trauma system side. This is all well and good, but how do we factor in a blood supply that's at risk and time and distance relationship in an EMS community that is already overtaxed?
Yeah, that's a great point. And certainly in our supplement, you have to give recommendations for everybody. So I think if you have a TAS blood system, or you have you're in a low resource setting, say in Africa, or even some place in the United States, component therapy is good. Don't get me wrong. It's improved mortality if you use it correctly. And I don't think we don't have the definitive answer in peds. Obviously there's data to show, and there's going to be data in adults to show. I think that whole blood is better, but if you don't have it, you can't give it. So you have to resuscitate how you can. And I think component therapy is still good. And I think that needs to be stressed. You can't, if you don't have it, you can't give it, but you can certainly mimic it. Yeah. Yep, I agree. Yeah. I trained at Vanderbilt in the crystalloid era, and a guy named Brian Cotton, who you may know from the literature, he would throw it in the trash can, and everybody thought he was crazy, but he's right.
Explain also to a general pediatrician the connection between coagulopathy and hemorrhagic shock. Those two separate conditions, or they're related?
No, they're related, and so in surgery we think about this triad of death. So cold, coagulopathic. So as the child or adult or anyone gets cold and they get coagulopathic, that just makes hemorrhagic shock worse, and then you can get into medical sort of bleeding that you can't stop, you can't correct. So if you get behind the 8 ball, so those two go hand in hand. If you have hemorrhagic shock, you're going to be more coagulopathic, and then the sort of, it just circles. So we call it circle of death.
And clarify, please, the coagulopathy, how does that increase the hemorrhage? I mean the shock.
Well, it may not increase the hemorrhage, but it increases the medical coagulopathy. So if you don't replace those factors, they're gone, and you dilute it with saline, it makes it even worse. So then it just becomes a big circle that you're chasing your tail.
We have a question from the chat.
Uh-huh.
You noted in your consensus recommendations a high plasma to RBC ratio. Our current emergency blood fridge contains both packed RBCs 6 and plasma 2 ABA plasma. Would this meet this need in lieu of LTOWB?
Our local, we have a blood fridge.
Yeah.
6 red and 2 with plasma.
Yeah.
I think they're talking about how what we're doing locally match up to your recommendation for the 1-to-1 ratio.
Yeah. So, I mean, I think the challenge is having thawed plasma. So I think if you're probably not going to get enough resuscitation in by the time you can get some thawed plasma. So if you give blood and those 2 of dried plasma, you're probably going to be okay until you can get your thawed plasma. But yeah, I would think about how to get that thawed plasma.
And for the person on the chat, the reason it's set up that way. And sorry, for the person on the chat that's listening, the reason it's set up that way in the local blood bank is because, or in the local blood fridge in the ED, is because the distance from the ED to our main blood bank. So that's fridge is really meant as just a bridge to start some blood while the MTP cooler is coming from the blood bank, which is on the other side of the medical center.
Well, I want to thank you for joining us today.
Yeah,
I
thanks
think
for having
this
me.
had broad appeal to our surgical and our medical audiences.
Yeah, appreciate it.